Yeah, let's make this interactive. So if you guys basically just ask questions as you come along, as we start, and I can see all of your names on the call, which is good. Uh, so yeah, just basically just call out and stop. Okay. So we've got you asked for two things. One was how to read a paper, how to critique a paper, and then the other one was talking about NJR. And I know you guys have got your FRCS curriculum, so we're talking about how to interpret basics uh, at the basic level, but also common questions that are asked, and also in relation to the NJR, how you look at the NJR as well. Okay, so the key things we'll do is research studies, basic research statistics, and presentation findings. There is some overlap of what we discussed last week, but hopefully this will go into a bit more practical application. So you never know with the FRCS, right? So like if you're given an abstract or any kind of critique, Hashim, I don't know what they did for you in your exam on the research side. Um,
Yeah, basically, he can give you. So I remember he gave me an. There was a systematic review comparing, I think, if I remember, between aspirin and one of the DWAC for total arthroplasty. And then he asked me, based on this study, what will you use and why?
yeah.
Then he wanted you to critique the whole paper and come with findings and why will you be choosing one over the other.
Yeah, so that's the typical FRCS, so it hasn't changed at all. And that's why the key is how you read things quickly and what information they want you to get. So last time we talked about briefly the pyramids, if you remember, the level of evidence pyramids. The types of studies that you can get in that pyramid can be split broadly into observational and experimental. Experimental means there's an intervention, so like a randomized control trial. Observational, you have no intervention. It's cohort, case control, or a cross-sectional study. Oh, this is the pyramid that we discussed last time, okay? And we're not going to go through this again, but you can see the reason why an experimental is higher than an observational is because there's no selection bias. With an observational study, like a case control and a cohort, there is a risk that you are seeing what you want to see. So you have a huge amount of patients and you're selecting what you want to see. Whereas with a randomized control trial, it's blinded. There's two arms, and you have a very clear control usually because you're comparing. You've got two arms to a trial. Okay. So when we look at a cohort study, we've got this population, and we're following them up usually prospectively. Okay. In a cohort study, you compare your exposed group to your non-exposed group. So, for example, I've got a cohort study in the NJR, and I want to compare total knees to patients with I want to compare unicompartmental knees to a total knee replacement. So my exposed group is the unicompartmental knee because that is the new intervention, and my non-exposed group is the total knee group. Another example, I have patients with hip osteoarthritis and healthy patients. Patients with hip osteoarthritis are my exposed group. Now, the outcome, you can set whatever you want. In the NJR, the outcome is always typically revision. So the occurrence of the event is revision. The non-occurrence of the event is no revision. With a case control, similar to what I said last time, you've got your cohort and you're looking backwards. Okay. So you've got your outcome, which could be, for example, all patients who have had a revision. And then I'm retrospectively looking back to identify where those patients are and who they are. what was the exposure? I want to look at what caused the outcome by picking the outcome measure first. Okay? Does that all make sense? The difference between a case control and a cohort. It's all about when your exposure is, and case control is when you look at your outcome and you're looking back. Randomized control trial we've discussed already, which is you've got usually two arms, but it can be many arms. Lots of very complicated randomized control design studies, and you're looking at your outcome. So, question, who's on the call? Why do we randomize? Who's on the call?
To prevent bias.
What kind of bias? So be specific in your exam. What kind of bias?
Selection bias. Selection bias.
Yeah, yeah. What's the difference between selection bias and allocation bias?
I don't know.
Yeah, it's a good question. So selection bias typically means you're biasing the group of individuals that you're selecting to be part of your cohort. Allocation bias, you're biasing how you choose which patient goes into each arm. So there is a difference. There's a difference between selection bias and allocation bias. Now, a randomized control trial is meant to overcome both. It's meant to overcome selection and allocation bias. Okay? So,
Sorry, Omar, can you repeat this again?
yeah, so there is a difference between selection bias and allocation bias. Okay, so selection bias, you can design a study where the group of individuals that you're including that form the whole study, your inclusion criteria for the whole study. Say, for example, you're looking at only a district general hospital patients between 18 and 40. That might not be a true inclusion criteria to one of the arms, but it's an inclusion criteria for the study population. So that's selection bias for the study population. Now, allocation bias is looking at what the treatment is to each group, your allocation to each treatment. So you could say something like, a good example is you're designing a trial or a study where you have patients who are, I'm only going to look at patients who have been diagnosed with knee osteoarthritis by one consultant in this area. Okay. Now there's an element of selection bias. And I want to then randomize those patients or group those patients to a total knee group and a unicompartmental knee group. That's an allocation bias, because I would then say that I'm only going to allocate those patients from my initial study population who are young to the unicompartmental knee group. So I've created both a selection bias in my cohort population, and I've created an allocation bias to one of my treatment arms. Does that make sense? Because
Yeah, clear. Yeah. Thank you.
Yeah. Cool. Why are randomized control trials better than cohort studies? We've already discussed this. But so what is blinding? Who can give me a good FRCS level answer for blinding?
Can I try?
Yeah, go for it, Amar.
I understand the concept, but to define it, I think it's concealment of patient allocation.
Before you give your answer, imagine that this is the FRCS. You're not going to say, "I think it is." I want you to be confident, even if you're wrong. So, let's treat it like a viva.
Okay.
Yeah.
Okay. So it's concealment of the patient allocation to the assessor and possibly the patient. It can be single blinding or double blinding. Single blinding is the concealment at the level of the patient alone. Double blinded is the concealment is at the level of the patient as well as the assessor.
Good. Really good answer. So interestingly, there's also triple blinding. So actually, typically blinding refers to the way that a patient is randomized, rather than the way that the patient is assessed. And so double-blind randomized control trials refer to both usually the physician and the patient to what treatment they received. Triple blinding is the patient, the clinician, and the assessor. Some people don't like to use the word triple blinding, but it exists. That's a terminology that is used, particularly in the US. So, but yeah, most studies are double-blind trials. Okay, great. That was a very good answer, Ahmed. That was really good. Exactly. That was actually a perfect answer in my opinion. Cool. Okay. We've kind of covered that. Double-blinded. Yeah. Okay, cool. So so obviously I've put here a p-value. Now, a p-value definition here is a number describing how likely it is that your data would have occurred by random chance. There's lots of definitions for p-values, and it's important that if you ever get asked this question, that you just learn it, because it can get very confusing. But the key concept and the key word you have to get into your answer is random chance. Okay? Random chance. P-value of less than 0.05 is set as a statistical significant. Be aware there is a big difference between statistical significance and clinical significance. Good example is if you're looking at I don't know, an angle, one of your angles, a hip knee ankle angle, your HKA angle, okay? If it's measured wrong by 0.1 degrees on a radiograph, and you have lots of patients, you might find a statistically significant difference. But is 0.1 degrees a clinically significant difference? Not really. So be aware there is a big difference between statistical significance and clinical significance. A confidence interval is it displays the probability that a parameter will fall between a pair of values around the mean. So it is essentially, it's a measure of uncertainty or certainty in a sampling method. Now, the wider the confidence interval, the more unreliable the result. This is absolutely key. You have to look at the confidence interval. The worst thing that an FRCS candidate or an academic can do is interpret p-values. No one even looks at p-values. When you're in research, no one looks at p-values. Everyone looks at the confidence intervals. If your confidence interval is really narrow, you have a very interesting result. If your confidence interval is very wide, okay, it's an interesting result, but why is it wide? Is your sampling method wrong? Have you designed the correct study? Is there what's happened? Okay. So that's really important to figure out, to analyze and interpret. So the wider the confidence interval, the more unreliable the result. Okay. And confidence interval is reflected in the p-value. So if a confidence interval crosses 1, it is not going to be statistically significant. The p-value is going to be greater than 0.05. Does that make sense? Does everyone understand the correlation between the p-value and the confidence interval? Okay, good.
Can you repeat again, please? Thank you.
Yeah. So a p-value and a confidence interval can both tell you if there is a statistical significance. A p-value of less than 0.05 tells you that the result is statistically significant. A confidence interval, if it does not cross 1, then it is also telling you that there is a statistical significance. P-value less than 0.05, statistically significant. Confidence interval that does not cross 1, also statistically significant. They should correlate. You will not have a p-value of less than 0.05 and a confidence interval that crosses 1. Because
Sorry, Omar, can I ask a question?
Yeah, absolutely.
So
Alma. Yeah.
about the one, you set the one as it is the line of no difference. Is it always do the case or only relative, only in relative
Always.
statistics?
It's always
Eh,
it's in any study, a confidence interval always so you can have a confidence interval that's between 10 and 20, but it doesn't cross one, right? Because it's the lower confidence interval is 10 and the higher confidence interval is 20. It doesn't cross one. It is statistically
No,
significant.
it depends on the statistical test used. If it is a relative statistics or absolute statistics, I think if it crosses zero in absolute statistics,
Oh,
it is
yeah,
considered.
yeah. I understand your question. Yeah. So that's true. So 0 or 1 typically are the markers. You're not
Yeah.
going to, because what they say is that the probability that you've got that result by chance is either 0 or 1. So yeah, you're right about relative and absolute, but I would not confuse that. I would always stick to the metric of 1 because 0 is confusing, because what you're saying when you're using 0 as your marker for confidence interval is that you've got some results that are negative, and that's usually very complicated statistical tests. For the purpose of orthopedics, pretty much most of the time it's always 1. The boundary is 1. So this is a good example, right? So there was a higher rate of revision in patients who have had a unicompartmental knee replacement than those with total knee replacements. So you can see here that the rate of revision of 1.86, 95% confidence interval of 1.5 to 2.3, and the p-value is less than 0.05. Okay, so here you've got a pretty narrow confidence interval, you know, and the p-value obviously reflects what's shown in the confidence interval, and this does not cross 1. This is pretty good. This is a pretty good result that I would interpret with strength. Okay. Next, similar question. There was a higher rate of revision in patients who had a patellofemoral replacement than those with total knee replacements. So again, 3.5 was the revision rate. 95%, 1.1 to 13.6. P-value still not less than 0.05 because the confidence interval did not cross 1. Okay? Now, here, the confidence interval is very wide. This tells me that there was probably a problem with this study, right? It's wide, it's wide. Confidence interval. So there was either a problem with the patients, there was a problem with the study design, there was probably, it may have been a problem with something else. Cool. Sorry guys, 1 second.
May I ask a question? Maybe it's a basic question.
It is, yeah, go for it.
Just maybe it's a basic question, but just I'm slightly confused. What does it mean it doesn't cross 1?
So when it doesn't cross 1 is it basically just doesn't cross 1 here. So you see here 1.1 to 13.6. If I wanted to cross 1, it would say, for example, 0.7 or 0.8 to 13.6.
Oh, okay.
Does that make sense?
Yeah. Thank you.
And then, yeah.
Thank you.
Yes, Ahmed. Yeah.
Sorry, Omar. There's a question about the randomization. So what's the difference between allocation concealment and masking? My understanding is allocation concealment, basically you don't know what is the next treatment will be. And masking is not knowing when you are analyzing the data, you're not aware what treatment this patient received. Is that correct?
Say that again slowly.
So allocation concealment, my understanding is that the investigator doesn't know what's the next treatment will be in allocation. So he doesn't know what treatment this patient will receive.
So yes.
So what? Yeah. So let's say that so the investigator doesn't know what's the next treatment on the list or in the randomization. So they don't choose a treatment or exclude a patient because they know this treatment will not be proper for them. So
yeah, I mean, the difference between allocation, blinding, and masking, concealment, and blinding is relative to whoever is the person in the process of the study or the trial. So a good way is, so blinding can be relative to anyone. Concealment typically, again, can be relevant to anyone in the study design except for the assessor. And masking, yeah, you would probably, in all honesty, you'll probably have to look at what the best definition is, because there's so much overlap between masking, concealment, and blinding. Hashem, I don't know if you have any thoughts on this. It's a good question, and I know that they can ask this type of question in the FRCS, and it would be mean because there's a lot of overlap.
So yeah, my understanding is if I am the investigator and I know what's the next treatment in the study or in the randomization, and when I get a patient, I wouldn't choose this patient to be included in the study, and I would go into selection bias because I know this treatment would favor or unfavor this individual over the other. So I would either select them or not select them based on me knowing what's the next treatment in the randomization. So that is allocation concealment, not to know what's the next treatment is. Okay. And masking or blinding means that you don't know what's the intervention that this patient received when you are like assessing or analyzing the results.
Yeah. Yeah, I mean, what you're saying is probably correct and very sensible, but I have met so many people that will use different words for essentially the opposite side. But what you said makes sense, so I just stick with that, Ahmed.
Okay.
Yeah, I'll stick with that. It would be mean for them to ask that kind of question. So going on to presenting a paper critique. So method and results are the key to everything. Ignore the introduction, ignore the conclusion. If you're given an abstract, the first thing you do is you look at the methods and the results. That's it. Methods and results is everything. And obviously this is not for the FRCS, but this is a really good tool to look at the structure and the checklists of how you should critique a paper. Okay, so I will click on it and then we will go through. Let me share my screen. It's going to stop it's going to stop the recording. So if I show you, okay. So you see here, if you guys go on this CASP website, it's really good. It's really, really good and really get into the habit of doing it. So I would start off. So the typical stuff they ask is nearly always meta-analysis. By and large, the most common question that you guys are asked in the FRCS is a meta-analysis or a randomized control trial. Okay. So typically so this checklist tells you how you should read your studies. So if you click on it, it will give you the PDF or Word document on how to interpret a study. So it will ask you the questions that you need to ask. Is the basic study design valid for a systematic review? And then it says, consider this, all of this stuff. does this. So basically, it's like a checklist that you go through when you're reading a paper. It's a long checklist, but I would suggest, and this will really help, is pick a systematic review or a meta-analysis and do at least once. Do it at least once, because the sections here are really, really good, where it says, consider here. Did the researchers present the key characteristics of the individual primary research studies? Did the researchers present the results of the individual primary research benefit studies in a forest plot? Like, it gives you hints how to read a paper. And if you do it once and it comes to your exam, you'll then understand how to go through it. Okay? So the first thing I always ask myself in when it comes to a quick abstract review is, what is the research question? Have they written a hypothesis? Okay. And I write out the PICO. So in the exam, and lots of people do this mentally, some people write it out, they would write, what is the PICO? So they would have PICO, participant, intervention, control, and outcome. Okay. This is really important because that's the first thing that you're going to describe to the examiner when you read the paper, when you've critiqued the paper. Okay, so this is a study that is looking at participants who have had osteoarthritis, who are over the age of 50 and have knee osteoarthritis in the United Kingdom. The intervention was a mobile bearing unicompartmental knee replacement, and the control was fixed bearing unicompartmental knee replacement, and the outcome was revision rate at 10 years. So that's typically what happens, what you would say. I would then ask myself on that study is, were the participants randomized, and what was the inclusion criteria? Okay, inclusion criteria is really, really important to read, because you will see a lot of big trials, and these are trials you guys should probably know and have read. UK Heal, Trial, Draft. There's obviously Draft 2 and 3 now. AIM, TopCat. These are all trials that, and probably Force, that is published in the New England Journal, published in the Lancet recently. So you should definitely read Force as well. What is the inclusion criteria? Did they look at the most relevant aspects, or did they just look for very obvious aspects? Was it blinded, single blind, double blind? Who assessed the outcome measure? Is this part of how good was the randomization and blinding? Okay. And then the third thing I look at is the follow-up. Were the patients followed up over an appropriate period of time? But more importantly, how many actually made it to the end point? This is really crucial, because if you have a randomized control trial, often what happens is you have one treatment arm that's doing really well. The patients are improving. They're very happy. And a lot of them get seen and follow up, and they're all happy. And then another arm where maybe the medication or the drug has not worked out very well. There's a problem with adherence. Classic thing is for wearable monitors. And then afterwards, classic adherence and portable monitors. And the classic thing is you have one arm that has 100% retention and another arm where the patients are not at 100%. So that's just something really important to work out. Okay, blinding and patient. So, but what I mean by that is, often in a trial, you'll have this flow chart. Make sure you look at the flow chart, but specifically the two arms at the bottom, right? So here you have 242, and here you have 260. Okay, they were allocated to removable brace to plaster cast. Okay, 242, 260. So pretty equal, not a huge difference. Okay, and then I would look at the table at the patient with demographics from the two groups. So were they also equal? Decompression alone or the fusion group alone? So again, make sure that roughly they should be equal, because they were randomized, right? So the whole point of randomization is that you've remove that element of bias, and so you're getting equal groups on both sides. Particularly here, like ASA, was one group more comorbid than the other group, and maybe that could be why the outcome is different. So you want to make sure that the groups are the same. Okay. When you're analyzing and critiquing a paper or an abstract, often, particularly for FRCS, and I'm sure you probably got this, Hashim, they will have an abstract or the paper, but there will be a graph, there'll be an infographic, and usually it is the graph and the infographic that they quiz you and push you more on. Hashim, did that happen to you in your exam?
I think Hashim left already.
Hashim's left. Okay, fine. But yeah, so that typically happens a lot.
So, Omar, can I ask a question? Sorry to interrupt.
Yeah, go ahead.
I think there has been change in the exam, because I know that for general surgery, they have like a whole half an hour station on this. Like they give you the paper, they give you 20 minutes to read it, then they come and quiz you for a half an hour. Is it the thing that you're talking about? Or because we are talking here about 5 minutes?
Yeah, 5 minutes. Yeah, 5 minutes. They can still give you 5 minutes, and they expect you to read an abstract and a graph. But double check, because the exam changes year on year. Like it changes, the format does change. So just double check with Hashim exactly what he had, because he did it last year. So double check what he had, but read the guidelines on what they are expecting of you. So yeah, so just double check.
Okay.
But typically, even when you go for any other interview, in the US, for example, they typically ask you a lot about data and research and what have you. So yeah, in any presentation, always copy and show the results. Cool. So now we're going to go on to, we've already discussed this last time, so we're not going to spend too much time, but you guys know how to assess this type of graph. What is this type of graph?
Forced plot.
Yeah.
Forced plot, yeah.
Yeah, good. Good. Okay, good. And always look at the results table. Always look at the results table. So you see here, analyze each bit. So length of stay, yes, there was a clear difference. Duration of surgery, clear difference. Clinically important improvement, no real difference, right? But more importantly, let's talk about these confidence intervals. Okay, what do you guys think of these confidence intervals? So why doesn't somebody explain duration of surgery and length of hospital stay?
It does look like it's below 1, isn't it? That's minus 80. Is that correct?
Yeah. So what do you think?
So as you say, in fairness, like I just understand it from you, it's not good, because it's below 1, or it's cross 1.
Does it cross 1? Does it cross 1?
Yeah.
How does it cross 1? Because it's this is minus 84 to minus 55, minus 2.4 to minus 2, minus 1.2.
So it's already I mean, it's below 1, but if that make any sense, so
remember, it's nothing to do with below 1. It crosses 1. I've never said below 1. It's always crosses 1.
Okay, so
tell me, what do you think of the results now for duration of surgery and length of hospital stay?
Sorry, Omar, you mean they didn't cross 1, that they are both negative or both positive?
They're both negative, right? So they're both negative. So one is minus 84 to minus 55. Okay? So that means this was statistically significant. Minus 84 to minus 55 is a wide confidence interval, but it is
wide.
Yeah, but it's statistically significant because it never crossed 1.
Yeah.
Right?
Yeah, but still wide.
Yeah, which also makes sense, because your intervention group, you are comparing the decompression alone versus fusion, and you can see here the duration of surgery for the decompression group was nearly 70 minutes quicker, right? Can you see that?
Yeah.
70 minutes quicker, up from nearly from 55 minutes quicker to all the way up to 84 minutes quicker. But it never crossed one. There was no period where it was slow. Okay? It didn't cross one, so
But
this means that it was statistically
yeah,
Significant.
Does
yeah,
that make
but
sense?
looking to the looking to the length of hospital stay,
Yeah,
confidence interval is slightly small. It's about 1.8, and still it doesn't cross one.
exactly. So that was
So
also statistically significant, right?
yes, but
Yeah,
with a narrow confidence interval, so it is good.
narrow.
Yeah.
So what do you think? What when you look at that, what does that tell you?
So the length.
Um,
Oh, sorry. Go ahead.
it tells
Yeah,
me
go for it.
that
Yeah.
it's significantly significant. Sorry, it's significant in the decompression group. It's lower um, length of hospital stay. Sig yeah, significantly better.
Yeah, I mean both were statistically significant, but duration of surgery, the confidence interval was wide, but length of hospital stay, the confidence interval was narrow. What that tells me is that there was more variation and more unpredictability towards improvements or making the duration of surgery quicker compared to length of hospital stay. I am more comfortable as a clinician to say that decompression alone reduced length of hospital stay more than I am saying that it made the operation quicker by 70 minutes.
Yeah, it's clear
Does
now.
that make
Yeah,
sense?
yeah,
Sorry. So you mean the length of stay, it's significant, and there is no difference between the two groups.
No,
But
There is a
oh,
difference. There is a difference.
okay.
It's statistically significant, right? So
Oh,
there is a difference. You can see here
yeah.
3.3 and then 5. And the difference is not 1.8. And the confidence interval did not cross 1. So yeah, there is a
Okay.
difference. Yeah.
Okay. Okay. Thank you.
Okay. Does that make sense to everyone? Because this is really important. Yeah. Does everyone understand the range, the wide and the narrow confidence intervals? Cool. So okay, so next person, somebody explain to me what they think about blood loss during surgery. Blood loss during surgery and wound infection during hospital stay.
I can say blood loss during surgery. Confidence interval is from minus 348 to minus. So this is still significantly with a wide range. All right.
Yeah. So yes, yeah. Yeah.
And the blood loss is crossing the one, so it's not significant with a narrow range.
Good. It crossed 1. Yeah, exactly. Exactly that. That is exactly it. You've answered it perfectly. So because it crosses 1, the wound infection is not statistically significant between the two groups, which makes sense, right? Because there was 0 infections during hospital stay for the decompression alone group, and there was also 0 infections in the fusion group, right?
yeah. So what does it mean by negative and positive? Does it make any information? Does it add any information to us?
No, it just means that it's not statistically significant. The minute that something is not statistically significant, you have to be very, very wary about interpreting it.
Okay.
Okay. What about cardiovascular complications during hospital stay?
It's not significant as well because the confidence interval -1 to 6.5. So yeah, I would be concerned about this results and interpretation.
Exactly. So interpret it in terms of decompression alone group and fusion group.
Yeah.
What do you think? How would you explain? If I asked you, were there any cardiovascular complication differences between the two groups during hospital stay?
I mean, clinically, there was 3 patients who with the compression group. However, statistically, there is no significant difference in comparison between the two groups.
Good man.
So yeah, that might happen by chance.
Good man. Good man. The way that I look at a critique and the way that you would interpret anything, you make your own conclusions. Never read the author's conclusions. If somebody gives you an abstract or gives you a paper, never read the conclusions. Always read the methods and the results, because the author, people make up their own conclusions. Okay? Write your own conclusions and see if you reach the same conclusion as the author. Okay? Now, I want you all to read this. Oh, sorry. So my question to you guys is, what is the difference between a superiority trial and a non-inferiority trial?
So can I answer?
Go for it, Ahmed. Yeah.
Yeah. So superiority trial looks for a new type of treatment offered compared to the standard type of treatment, that this treatment, the new treatment, is better than the already established standard treatment method. The non-inferiority trial looks at another treatment which is compared to the current treatment in terms of it is not worse. The question is it worse than the current treatment or not? Especially if the new treatment is cheaper, for example, or more convenient in terms of the processing of of this, maybe easier technically, but we are now looking if does it have more complications, does it have more mortality rates, rather than looking at the actual results in terms of the benefits to the patient.
Okay, so that's not exactly true, what you've just said. So a superiority trial and the difference between a superiority trial and a non-inferiority trial is, what is your intent in the study design? What is your intent in what you want to look at? If you have a treatment that you think is better than the current standard, your statistical tests and the power that you do and your outcome measure is all about trying to prove a better result. So it's all to do with the statistical test and your marker of outcome. A non-inferiority, you are basically saying that I am designing this trial and this study to show that this current treatment is no different to the current gold standard. Does that make sense? So it is all about the statistical test, the intent of the trial, and the study design. Does that make sense?
Can you repeat it again?
Yeah.
Sorry,
Yeah.
please.
A superiority trial aims to prove that your new intervention is better than the existing one. An inferiority trial aims to show or prove that your intervention is equivalent and no better than the existing one. Now you might ask, so why are you doing an inferiority trial, a non-inferiority trial? What's the point? Why do you think non-inferiority trials exist?
To confirm that the result was not like happening chance, or just to prove.
No, well, the reason why you do a non-inferiority trial is because your intervention that you have, that you want to say is non-inferior to the existing, is cheaper or has a more safe side effect profile. So you know that the existing standard has a good outcome, but you are proving to the health economics and the health service and the patients that your trial can produce the same, your intervention can produce the same results, but has extra advantages. Does that make sense?
Yeah, so it's a different intervention from that we already have.
Exactly.
Yeah. Okay.
Yeah, but it could be cheaper. It's cheaper, but you want to show that it's still good. So a great example, okay? Say I have say I have a non-steroidal and my outcome measure is pain, is the VAS score. And I think my non-steroidal is just as effective as an expensive biologic, and it's non-inferior to this expensive biologic in showing the same kind of improvement in pain. So I can design a non-inferiority trial. That would be a very good study design for answering that type of question.
Can we give an example like a cordless trial or draft one trial? Because cordless, when they at the end of the day, they have the collagenase expensive compare the fasciotomy or the needles, and the draft one also the K wires similar or cheaper than the volar plate.
Yeah, those are great examples. So, but technically, draft was not intended to be a non-inferiority study design, right?
Yeah, but I mean the result is sort of.
But it's still not a non-inferiority study trial.
Okay, so it should be intended from the beginning why you do the study, is it?
Exactly. You should absolutely, it's all about because the statistical methods that you employ to analyze your data is different in a non-inferiority trial to a superiority trial. And your outcome measure might also be different. Cool. Then you have a question of generalizability. So if you did a study or a really big randomized control trial in Egypt, does it mean that you're going to see the same results in the UK or anywhere else in the world? Would you change your practice? Is the surgery performed similar? Are there any other outcomes you would have wanted? How generalizable and valid are your results and your study or this study? Okay. I want you guys to, I don't know if you guys can read that. Just a task for all of you is, can you read that? And I want you to basically, everything that we discussed about study design, I want you to critiquing a paper, sorry. I want you to read this study. So you've got 5 minutes, okay? And I want you to critique this abstract. Oh, sorry.
It's become blurred.
Is it blurry?
It's come back. It came back. That was it.
Hi, Omar. Shall I try?
Yeah. Give everyone else 2 more minutes. Give everyone else 2 more minutes. Okay, good. Okay, so let's go. Why don't you go, Ahmed? You put your
Yeah.
go for it.
So if we analyze first, we'll say our population will be the people who had calcaneal fracture above the age of 16 years old with displaced intra-articular fracture of the calcaneus. And the intervention will be open-reduction internal fixation versus the control, which is the non-operative management. And the outcome will be over 60 months analyzed through the uh, which scoring it is like the Keir-Atkins scores, I believe.
Okay.
So the randomization, when we look at it, 52 patients had ORIF and 62 were non-operative. I don't see the inclusion criteria here. I cannot
Yep, this is just the
judge.
abstract. Yep.
Yeah, exactly. And then
Good you
when we
commented. That's good you commented. Yeah.
yeah, and when we look at the outcomes now, so comparing so if we read the mean Keir-Atkins score were 79.2 for ORIF and 76.4 for non-operative. So now I'm looking at the confidence interval. It is in between -8 to 8.5, which is crossing 1, which is a very wide and wide rate. And the p-value is 0.9, which is high. So this is statistically not significant in favor of ORIF. And then looking at so this is what was written. There were no between the difference. So I think So this the main thing that there is no wide confidence interval with statistically no significance in doing an operative management, and they concluded that at the in the summary of the paper that the ORIF versus non-operative doesn't show any statistical significant difference.
Good. Very good. I like that a lot. Well done. Does anyone
Can I
want
add
to
another?
add anything? Does anyone? Yep.
Yeah, so it's not clear how we differentiate between patients who will get operative and non-operative, who will
Good.
be the case and control.
Good man.
So it's not clear what's the type of randomization. So yeah, I'm concerned about biasing in this trial as well.
Good man.
Yeah. So in conclusion, for me, I will not relying on the results of this paper to change my management.
Good man. So what would you do?
Well, I'll try to find another randomized control trial to have like better inclusion, clear inclusion criteria, good randomization to avoid biasing. Yeah, and to have a smaller or narrower confidence interval between the results not crossing 1, so to have a significant result.
Yeah.
So I
Be
can
careful
rely on.
whenever you're reporting. Don't say, not results crossing 1. Don't say that. Just know it.
Okay.
Because just
Yeah,
don't
yeah.
say it.
Okay.
These are just tips and tricks, but just say that statistically significant. I will try and make sure
Okay.
that the study, I know what the power of the study is and all of that.
Yeah.
Can I try, Omar, and trying to?
Yeah, say that again.
Hello. Yeah.
Yeah.
Can I try to critique the
Yeah, go for it. Yeah. Go for it.
So
yeah,
I'm not sure if I can say pros and cons. Can I say that in the exam, or it's not like because not all the paper are having like a critique, meaning we only say the negative things that we think, or we can say appraisal, like we can say that
good
this
man.
paper
Yeah,
has.
I agree. I think you should say some good things as well. I think, I agree. I do agree.
Yeah. So if I say in terms of methodology, they had a clear inclusion for the patient, inclusion criteria. It's not well explained here, but they explicitly mentioned intra-articular fracture of the calcaneus with significant deformity and fibular impingement, which is really specific. And they had a good assessment tool. They used a Kerr-Atkins score, which is, I think, it relies on the clinician assessment, and they used as well self-reported difficulty walking, which is it's a PROM, patient-reported outcome measure, and fitting the score. And as well, they included additional surgical procedure, which is like an endpoint to the an endpoint, like an event to the outcome later on. The thing the negative things that you can see, that they only included 118 patients out of 151 were included, and I don't see here any comment on where are the missing data, where are the rest of the patient has gone. And they used the mixed effect regression analysis, which I think is it something like a retro, something to the patients were I'm not sure about this. This is not like the typical statistical test that you will use in a randomized control trial. I think regression analysis are mainly used for retrospective analysis, is it, or I'm wrong?
Yeah, so never comment on a test if you don't know it, because remember, this is this would have been £1 million plus randomized trial. They would have had professional statisticians doing the correct tests. It's published in the Bone and Joint Journal, a respectable journal. So I would never critique. Just always be very careful about critiquing. Yeah.
So, I think that would be all the things that I'm just the effect size is minus 0.14. I understand that effect size to be considered of meaningful. It should be 0.5 or more, but here it is with the minus.
Yeah. So be very careful, because effect size can mean lots of different things as well. So yeah, be very careful. But yeah, typically an effect size of 0.5 is considered to be meaningful. That's true. But I would not, no one expects you to know that.
So a question, Omar, please. Do we need to have a single p-value in the whole study? Because here there is many p-values.
So good question. You have to interpret, because remember, they looked at different outcomes. Look, we report Kerr-Atkins scores, self-reported difficulty walking and fitting shoes, additional surgical procedures. So they did multiple, they probably had their main outcome, which is the Kerr-Atkins score. Okay, but then they had multiple other outcomes, secondary outcomes, that they would have had a p-value for, because they would have analyzed those. So that's what they're reporting here. So they've reported the Kerr-Atkins, they've also reported the difficulty walking, type of shoes, and they've also reported on additional surgical procedures. So all of those would have had a p-value.
So what does it tell if you have very high p-value like 0.9 and very
It's
low.
It's not statistically significant.
It's not.
Either there was a problem with the study design, there was a problem with the patient selection, or there was a problem, or a study was underpowered, so they didn't have enough patients in the group, or there really was no difference between the two interventions. This is the type of study in the result where I come out of it not knowing what the answer is. So I would do another randomized control trial, or I would include this randomized control trial and do a meta-analysis to other randomized control trials that have looked at similar things.
Do you mind if I try to add a few things and
Go
you can
for it,
correct me if
Hassan.
it's right or
Go
wrong,
for it.
please?
Yeah, absolutely. Go for it.
So I can see that this study doesn't show what is the method of randomization used, so you cannot reproduce it later. So if you'd like to reproduce this design again, it's not possible to reproduce it. It's also like said that it is long-term outcomes, while I personally cannot see what they mean by long-term outcomes. Is it like how many years? Because I think that the duration of the study wasn't long enough to reproduce long-term outcomes.
I mean, 60 months is a long term. I disagree with that. I think 60 months is very good. 60 months for 118 patients, that's a good study.
Okay. Can you still hear me?
Yeah.
So again, what I'd like to add that there is no so the scoring system that I use, which is a Kerr-Atkinson score, is a non-specific score. It could rely on multi things. So it's just pain, ability to walk, and these things. It just you can have an affection from other joints, such as an ankle, such as a knee, such as a hip. So it's not a specific score. So I cannot set this parameter as it's just related to the subtalar problem or the calcaneal problem only.
Okay. Yeah, I mean, a lot of the stuff you're saying is probably available in the supplementary materials and the rest of the paper. So what I would comment is, based upon this existing abstract and limited information, I would want to read the whole paper and the supplementary materials, looking at their inclusion criteria to understand exactly what they looked at in terms of the closed displaced intra-articular fractures of the calcaneus. And was that up to the surgeon's choice, or was there a strict protocol?
Yeah, that's fine.
Okay, good. Good stuff. Cool. Very good. So it's as I said last time, guys, I prefer only to do an hour because it gives everyone enough time to understand what we went through. And also I'm a little bit unwell. So key take homes from today. Okay, we looked at types of studies, observational versus interventional. We've already talked about the pyramid. We've looked at cohort and we've looked at case control and randomized control trials and different allocation. We talked about bias, blinding, concealment, masking. Okay, the difference between blinded and double blinded. We talked about confidence interval and the importance of looking at the confidence interval and whether it's wide or narrow. We talked about how to critique or appraise a paper, and I recommend everyone uses the CASP tool at least once for one paper, preferably a meta-analysis. I think that's usually the most common FRCS style study. And then we talked about the different things that you would ask when you're going through a paper. What is the research question? Randomized and blinding. What is the follow-up? Blinding and the patient characteristics. Looking at the results tables, the graphs. Again, always look at the results. And then look at your own conclusions from what you've seen and compare it to what they've written. Okay? We talked about superiority and non-inferiority. And we talked about generalizability. So, does my study, can it influence my practice with my population group in a different country or in a different center? Or or was it not very generalizable? And we analyzed and critiqued the UK HEAL trial. Okay, guys? So I will yeah, we'll schedule the next session for whenever you guys want. Usually Thursdays are the best days for me. And yeah, does that sound good?
Thank you very
There's
much,
only
Omar.
one Thursday left. It will be on the 17th. 24 will be 3 days before the exam. So can we set it on 70? Because I think NGR reports are an important thing to understand.
Okay. I'm happy to do tomorrow. I'm happy to do tomorrow 5 p.m., 6 p.m. UK time.
6 would be nice.
Yeah, I'm happy to
Yeah.
do that. If you guys
Yeah.
liaise with Hashim, drop him a message on the WhatsApp group or whatever. I'm happy to do 5 p.m., 6 p.m. UK time.
Thank you, Omar, for your time.
Thank you.
We
Thank you
need
very
Yeah,
much.
6 p.m. is
NGR
fine.
that funnel plots, because I think we've gone through whole graphs that could come in the exam. The only one which is I think it's important in the funnel plot.
So we've done funnel plots already last week, but we'll do the NJR funnel plots tomorrow.
Okay, good.
Yeah, the
That's
NGR
good.
funnel
Thank you very much,
funnel
Omar.
plot, what I
Thank
mean,
you.
yeah.
Okay.
Thank you very much.
Thank you very much. Thank you. Bye-bye.
Thanks, Omar. Thank you.
Bye.